One, welcome to part 2 of chapter 27. Chapter 27, fluid and electrolyte acid base balance. Where we left off last class is we had just discussed the types of buffer systems. Now, what we're going to go into is the foundations for understanding the diseases of acid base imbalance, specifically that of respiratory and metabolic acid base disorders that I want to discuss. Now, to grasp that, if we see that the lungs can add and remove stuff from the body, and that we also can excrete hydrogen ions in the fluids, for example, using the kidneys. Renal compensation, then we'll understand these two things. And that's what we're going to get into: respiratory compensation and renal compensation. Now, we are discussing here specifically the carbonic acid bicarbonate buffer system. Now, let me kind of talk about what happens. It's a very powerful buffer system throughout the body, but it has its limitations and it gets overwhelmed. Now, there are two things we can do to compensate to help maintain a pH balance in our extracellular fluid. We can affect what's called respiratory compensation. This is changing respiratory rate, so I can basically remove carbon dioxide from the body, which will ultimately then cause a pH increase by removing CO2. Now, what we always want to do is kind of remember that it affects that system respiratory rate. By changing the respiratory rate, I change carbon dioxide in my body. If I breathe more deeply and quickly, I can remove carbon dioxide from the body. And if I breathe more slowly and more shallowly, I can let CO2 accumulate. Now, when this happens, we should know that we change the pH of the body fluids. For example, if I ever increase my carbon dioxide levels, my pH will begin to decrease, and this is more acidic. That drives the system to the right. That causes hydrogen ion accumulation. But if I remove CO2, I can, by breathing more rapidly and more deeply, CO2 is removed, so the pH goes up. It gets more basic. And that goes to the left of our bicarbonate system, gets pushed to the left. Remember, the idea, what I drew out last time, was that there is shifts, that we said this was a type of reaction that is called an equilibrium reaction, and that in equilibrium reactions, you can move these to the left or to the right. Now, what I want to help us understand is if that respiratory rate goes up, CO2 is removed. Hence, you're going to remove the CO2. You're going to increase the pH, making it more basic. And if the respiratory rate goes down, you are going to allow CO2 to accumulate by then decreasing the pH and making the blood more acidic. And that is the basis behind respiratory compensation. Now, renal compensation is going to affect two major things. I can change hydrogen ions using, for example, the distal convoluted tubule, things like that, to affect bicarbonate level and things like that. If you look in my notes dealing with the urinary system, we talk about urine formation, and one of the slides that I have, we begin to discuss some things there about bicarbonate being adjusted at different places, things like that. We talk about bicarbonate can be adjusted in there. So just reminding you guys of that. Now, what we do is if I have too much hydrogen ions and I'm acidotic, I can use the kidneys to urinate those out. Aldosterone, remember, can cause the excretion of that. Not only that, but we can generate bicarbonate ions in the kidney and secrete those, put those in the bloodstream, reabsorb them and get them into the bloodstream. Alkalosis, on the other hand, when there's not enough hydrogen ions, you can choose not to excrete those. You can retain any hydrogen ions that we get, and also help to get bicarbonate out, secrete it, urinate it out. And that would be renal compensation to adjust the secretion and generation of various ions in the body, the bicarbonate and the hydrogen ions. And we could see that the kidneys can help affect bicarbonate, and by secreting hydrogen ions and generating bicarbonate. Or we can urinate out bicarbonate and we can generate hydrogen ions. And so with these two things going involved here is the lungs are involved and the kidneys are involved. And that gets us into our acid-base disorders. And what I want to help us understand here is that when any time that basically respiratory acid-base disorders and metabolic, the big thing with respiratory is going to be about carbon dioxide. It's either that there is you're making more CO2 than you're removing, or you're removing more CO2 than you can generate. And both of those things, either over accumulating or removing it too much, will affect the amount of CO2 in the blood, which will affect the acidity of the blood. And abnormal CO2 levels too high or too low, both of those will be bad. If you have too much CO2, you become acidotic. If you have too little CO2 in the blood, you can become alkalotic. And then metabolic acid-base disorders, they basically result because I'm overproducing your metabolic stuff, metabolic fixed acids. And this also can affect your bicarbonate. One of those things I'll talk about here is this. I'll go ahead and talk about Rome, how bicarbonate metabolic is equal. You'll see bicarbonate and pH go in the same direction. Respiratory is opposite. CO2 and pH go in opposite directions. That'll be kind of a useful little thing. So as we talk about this, let's go into respiratory acidosis. Now remember, respiratory acid-base disorders, we are dealing with the lungs. So if we're talking about respiratory, okay, and anytime I'm talking about respiratory, we want to be thinking CO2 imbalance, okay? There is a CO2 imbalance here. Now, when we deal with these, I'm going to split this in half so I could save this paper that I'm using. I'm using some of the papers that I have because I've filled up my, and I haven't had time to clean up my rocket book yet. I will get rid of some of the drawings in there. I've got to make a video to get rid of all of them. But what we're going to do is we're going to talk about respiratory. And the first one we're discussing here is respiratory acidosis. Respiratory acidosis. So we're going to go here and talk about respiratory acidosis. And one of the things I want to talk about is with acidosis. When you're dealing with acidosis, this means we have an elevated hydrogen ion, okay? This means it is acidic, okay? Acidosis versus alkalosis. Acidosis, you're sliding down the pH. Alkalosis, you're kicking up the pH. So this means that I also have a very low pH. Now, in my notes, you may remember way back, and I told you guys you needed to memorize this relationship. This was something I kept saying, hey, if we ever increase CO2, this must mean that I also will increase the hydrogen ions, which means I also have decreased the pH, and that is something you need to know. This relationship is crucial to grasp. So with this, what we're going to do, guys, is I'm going to help you draw out this bicarbonate buffer system. We're going to do it every time, so we'll have it 4 more times of seeing it. Remember that carbon dioxide gas reacts with water, H2O, and we form what is referred to as an equilibrium reaction here. And this equilibrium reaction, H2CO3, which is carbonic acid, and that will dissociate into H plus and HCO3 minus, which is bicarbonate ion. Now, 2 things I want to do. First off, let's sketch right under here. And I hope you can't hear my dogs over I don't know how good my noise canceling headphones are. But they must be one just been taken out after dinner to go potty. So one's barking, then the other one's out. So, all right. Now, we have the lungs and we have the kidneys here. And this is integral to the physiology. So what I'm going to do is I am going to zoom in on this, just kind of help us understand it a little bit better. I will zoom in. I want to talk about this. Now, with respiratory acidosis, I'm going to use 2 colors here, and what I like to do when I do it is I just like to use red and blue. And what I always like to do is red is going to be the cause. It could be cause here. And when you're dealing with respiratory, okay, respiratory means lungs. Now, what would cause the result here is to become acidotic. Remember, this means I have to have an increase in CO2. We know that is happening, okay? We know that CO2 levels are elevating. Now, there are a few reasons this might happen. One very common reason could be a decrease in respiratory rate, or some kind of decrease in ventilation. You're not getting air in, like asthma, things like that. So I'll say alveolar ventilation. You're not getting enough air in. Asthma, some kind of restrictive disorder, something that is preventing pneumonia, something that is decreasing the lungs' capacity to function. But whatever this is, your CO2 is building up. So what's going to happen is, remember, this idea on an equilibrium that I said is anytime that I move something up on one side of an equilibrium, the reaction always shifts in the other direction, which will start to cause an increase in these hydrogen ions. Will start to build up in the body, hence acidosis. Now, one of the things I always like to make sure that we mention here, and this is something I want to talk about, and I'm going to use this right here, my little table I made, is in respiratory acid-based disorders, our bicarbonate should always stay normal. That is one of the things you'll use. There is a thing I'll mention called anion gap, help you tell between compensated versus non-compensated acidosis, alkalosis, but that is a whole different thing. Now, what I also just want to mention as I'm drawing with this, guys, is that we are going to have see, I can't tell if this is just me. Okay, there we go. If it was my glasses or it was my anything else here. Okay, so our body has done this. What we're going to do is with those hydrogen ions have accumulated. Now, bicarb stays normal. So a few things that you're going to try to do. Now, first off, response-wise, I could try to just get my respiratory rate back to normal. Try to get the respiratory rate to go up. That will help. Now, that may not be something you can do if you have a disease that is preventing that. Okay? Now, if you are normal, what that will start to do is drop the CO2 levels. And that as that happens, these hydrogen ions will get shifted over here. Now, this should be our normal first response, is if I hold my breath, I will desire to breathe. And this is what my body's going to want to do. Now, we have, though, these hydrogen ions that are there. We so happen to have something called renal compensation. What I can do renally is pull out hydrogen ions and urinate them out. Okay, secrete them, put them into urine and get rid of them. That is one very good way to really dramatically lower them is with renal compensation assisting my ventilation, especially if in this case where my CO2 levels have accumulated and I want to try to pull the CO2 out by increasing respiratory rate. Now, also, because this is acidosis and bicarbonate is a weak base, we may be able to generate some bicarb from the urine, and kidneys can generate bicarb and add that as well. And that extra bicarb will neutralize some of these extra hydrogen ions. And so you have renal compensation will do that. Okay. Now, it may be that I need to put the patient on oxygen. Maybe they need to be added on oxygen. So, for example, I may have a patient with COPD, something like that. If they have a chronic kind of condition like COPD, where you put them on oxygen, emphysema, those kinds of things, where it took them a while to get that, or something that happened very quickly, something caused the respiratory rate to drop very fast. Maybe a neurological injury, but that happened suddenly. Um, Maybe they took drugs, and that those drugs were making the respiratory rate go down, things like that. But this is how the body would generally tend to deal with this. Now, what I do want to mention as I'm going into that lecture is hypoventilation, low breathing rate, primary cause. Now, acute is if the decline is very severe, very immediate, life-threatening condition. This can happen very quickly. Why does it happen very quickly? It could happen very quickly because of a drug you've taken, something that is an injury. Let's say they were in a car wreck and damaged a phrenic nerve. That might be able to cause an immediate life-threatening condition where it's extremely quick. Chronic, this is normal respiratory function has been compromised. This might be like COPD, emphysema, things like that. So anytime CO2 goes up, remember pH is going to drop, hydrogen ions are raised. Now, decreased respiratory rate, COPD, emphysema are very common causes. And we talk about what happens. Now, other buffer systems can also grab up hydrogen ions, like any other of the systems we talked about. For example, your protein buffers, your hemoglobin buffer system may also try, but especially the protein buffers may also try to accept some of those hydrogen ions. But it's the big things here, and just what I drew. Now, if we got respiratory alkalosis, let's talk. Respiratory acidosis. Let's talk respiratory alkalosis. Let's talk respiratory alkalosis. Now, what I like to do, and I'd always talk about these, is with respiratory alkalosis. Now, what we have to think about here is what an alkalosis means. Alkalosis, remember, we are saying something is basic. So that means a lowered hydrogen ion, which means we have an increase in pH, and this definitely means I have to have low carbon dioxide levels. Now, why might this happen? We're going to talk about that. Now, again, carbon dioxide, let me get this in here where we can see it. I almost forgot to do that. Carbon dioxide will chemically react with water, and this will form an equilibrium reaction of H2CO3, carbonic acid, which will also dissociate into hydrogen ions and HCO3 minus bicarbonate ions. We also want to make sure that we add our lungs here, and kidney over here as we go to do this so we can understand what has happened from a physiology standpoint. Now, we already said the cause here, ultimately we have low CO2. Why would CO2 be very low? Well, this could be caused by a very rapid respiratory rate, hyperventilating. Okay, hyperventilation. I almost put my arrow going the wrong direction there. You're hyperventilating. Now, very common thing, like for example, with a panic attack. Okay. Now, that could be a cause. And what that is doing is, as this pulls down, remember, these hydrogen ions, they are going to be pulled out, making them very low, which is removing, and that means basically, even though your bicarb stays normal to its 20 to 28 mil equivalents, it's still relatively higher, and other bases and things like that. So we've removed our most important acid from our body, so our pH has gone up. It has caused an increase. Now, with this, there are a few things you can try to do. Now, first thing your body is probably going to try to do, since this is respiratory, is we're going to try to get the respiratory rate down. If that happens, CO2 will start to accumulate back to normal again. Now, it is so, like, if somebody is having a panic attack and you get their breathing under control, that will happen. Now, that hyperventilation, it could be for other reasons. I don't want you guys to think that's the only reason, but let's say, for example, they took a drug that makes them do that, makes them breathe very rapidly. Something along those lines. That can actually cause a problem there. So if they were to overdo that. Now, commonly here, what they might do is let you breathe into a paper bag, and as that happens, the CO2 levels will go back up, helping to reduce this. Now, as we also think about it, remember, one of the big things we can do is, though this is normal, we can pull out the bicarb and urinate it out and get it out of the body. And then I can go in and generate hydrogen ions at the kidneys and get those in, along with the renal compensation alongside of our normal respiratory function, especially if normal respiratory functions are inadequate. Okay. So, loads of things we can see there. Okay. Now, what I want to do as I do this, let's go in and talk about that a little bit. As I said, this is what it does. Hyperventilation is a thing that is most common. That could be from a panic attack. One of the things you may, now I'm going to say this, you really need to know what is going on with a patient before you have them do things like breathe into a paper bag. It is a very common mistake I have seen. People have mentioned that, hey, I went and did that. And it's like they got worse. You actually, without knowing why they are hyperventilating, you actually could kill them. It is very important you don't just have them breathe into a paper bag for no reason. It is a very important thing to understand, is why they might have been hyperventilating. Hyperventilation is sometimes, as we're getting ready to see, could be a sign of a metabolic acid-base disorder. So let's get into metabolic diseases. Now remember, metabolic, we are dealing with the overproduction of metabolic acid, some kind of impaired metabolism that we're dealing with. So here, if we're dealing with metabolic, one of the big things we're going to always be thinking about is is Rome. Respiratory, opposite. Metabolic is equal. CO2 and pH always go opposite. But metabolic is equal. HCO3 minus and pH always go same. Okay. So I want to talk about bicarb here. Bicarb is a big one. Now, is that we know that it's metabolic acids, so metabolic issues. We'll talk about metabolic impairment. So let's talk about that. The first one I want to mention here is metabolic acidosis. Metabolic acidosis. Now, as we talk about this, remember acidosis. You're dealing with something that's acidic. So remember, if it's acidic, that equals a low pH, okay? Which might, now that could equal a high CO2 level, but in this case, CO2 is not the culprit, but this is a high level of hydrogen ion, okay? Now, it's not CO2, it's going to be like metabolic acids, uric acid, stuff like that, lactic acid, those kinds of metabolic acids. Now, as this happens, we want to kind of understand why does this occur. Well, let's look at our bicarbonate buffer system. We know that carbon dioxide, that it reacts with water in the body. We then have a reaction that we said is a equilibrium reaction, and we produce from that H2CO3, carbonic acid. Carbonic acid dissociates into hydrogen ions and HCO3 minus bicarbonate ions. What I'm going to do now is go ahead and zoom in here and make sure that we put our lungs here with CO2 always. Make sure that we put our kidneys under here so we know what's going on. Now, biochemically, we know that we have elevated hydrogen ion. That's the cause. We know that's what's happening, is high levels of hydrogen. Why might that be? If a patient has diabetes and they go in diabetic ketoacidosis, somebody's in starvation and they go into lactic acidosis. They have been severely exercising, lactic acid builds up in their body, something like that. So metabolic acids are coming in high and they are overwhelming any of the bicarb that you have. So we might even begin to say, guys, is that with the elevated hydrogen ions, remember our pH is low, so that means our bicarbonate is low. We can have low bicarbonate because all these excess hydrogen ions are annihilating them. If I'm making extra hydrogen ions out here constantly because I'm diabetic and I'm making all these hydrogen ions, then they're going to keep annihilating any bicarbonate that I have in reserve. And I'm just going to get rid of it. So I'm going to have very low bicarbonate. Of course, we have high hydrogen ions because we are impaired in metabolism. Now, with this, let's really begin with the area that should first kind of deal with the problem. Because these are acids, metabolic acids, usually get just urinated. So my body is going to try to urinate out hydrogen ions and these acids like uric acid, things like that. And it's going to simultaneously try to generate bicarbonate ions as we are trying to get these back up again and these back down again to normal. Now, one of the things this high level here is going to do, okay, is remember, if I increase something on one side, I shift it to the other side. So this will cause a shift here. And one of the things I will do, sorry, I was going to do this. I want to lower that by doing what? Increasing my respiratory rate. If I can breathe a little faster, I can start to pulling that out by turning this back to carbonic acid, carbonic anhydrase, and then that goes back to CO2, etc. Bam, we breathe it out by increasing your respiratory rate. That's a respiratory compensation for metabolic acidosis. Now, this can be lactic acidosis or diabetic ketoacidosis. Now, let me tell you, one of the very important things is, as a healthcare professional, you kind of have to know what's going on and what has happened with the patient. Now, it might be tempting. If you walked in and you saw a patient going, panting and breathing like that, you might be like, here, breathe in this paper bag. But if they're doing respiratory compensation for a metabolic acidosis, you have just killed them potentially. You could have killed that patient by doing that. What you want to do is know why they're doing that. So you don't just act, you have to find out. Like if their loved one's in the room, or maybe they have a medical alert bracelet that says they are diabetic. And you might say, hey, they're saying, and then also you might want to do is in metabolic acidosis, and they're breathing, smell their breath. Their breath will oftentimes smell a little bit like fingernail polish remover because of the ketones that are going to be found in there. Remember, ketones are just a type of organic compound. We don't talk about them in here. I do in my majors biology course. If you have me for majors biology at some point, nobody in this class is currently taking me as heavy for majors I know of, but ketones are a chemical that is the basis for many of our sugars. They're either aldehydes or ketones. Now, those things can break up so you can smell the breath. Okay, that might be an indicator and things like that. And if you and so these patients, you would only give them bicarbonate. You can give them bicarbonate. You can give bicarb to acidosis patients as a treatment. Okay. Now, as I mentioned, there are really two types called lactic acidosis and diabetic ketoacidosis, or ketoacidosis, which is indicative of diabetes mellitus, or also, for example, starvation could cause ketoacidoses. Oxygen debt causes lactic acidosis. Remember we talked about lactic acid formation during the idea when you don't have enough oxygen, this happens in a process called fermentation, where the body makes lactic acid, a 3-carbon acid, 3-carbon organic carboxylic acid, and it's that lactic acid is a very important acid for that. It's a carboxylic acid. Part of the muscle burn, things like that. Ketoacidosis, the ketone groups build up if you're starving or diabetic, diabetes acidosis. Now, renal failure is one of the causes. You could drop, like if you have diarrhea, you also could lose bicarbonate through diarrhea because bicarbonate is a component of the pancreatic juices that are added, and they can be removed from the body instead of reclaimed. So again, we're going to try to increase respiratory rate to remove acids. That's a respiratory compensation. Now, our big goal is always kind of think renal's the main one. That's the one that really probably is going to be kicking in first. And if you're healthy kidneys, then that's fine. Other buffer systems always kick in to kind of do the things like if it's acidosis, they're going to grab up the acids. If it's alkalosis, they're going to let go of acids and things like that. So let's talk about metabolic alkalosis. What is alkalosis? Well, we already kind of know alkalosis, you're kicking up the pH. So let's talk about metabolic alkalosis. Now, in metabolic alkalosis, remember alkalosis, we are dealing with basic, which we would say is a high pH, which we could say means I have low hydrogen ions. So in this case, I'm just going to go ahead and say that you also will have a lot of bicarb, extra bicarbonate. Okay, bicarbonate is a weak base. So what we want to do, let's talk about this thing. Now, again, our favorite chemical reaction, carbon dioxide reacts with water. That will form chemically H2CO3 carbonic acid. Carbonic acid will dissociate into hydrogen ions and HCO3 minus bicarbonate. And again, always, as you write this out, just make sure that you're putting your lungs under there, your kidney under that, so that you know physiologically what's happening. Now, in this case, we always say that we have a high level of bicarb, which also means hydrogen ions are low. Now, this can be caused for a few reasons. One of the big things that happens is actually vomiting. When you vomit, when someone vomits during emesis, you vomit, and stomach gastric juice, remember, has a pH of 2, carries around hydrogen ions. Now, what I want to help you guys understand here is if I excessively vomit, that can happen. That can cause the drop of this, your bicarbonate levels. Excessive vomiting is a really big one. Loss of stomach acid. Now, anything that can actually cause the increase in bicarb can also do this. Now, what our body is going to do is now automatically we have hydrogen ions. So you're automatically thinking, if I don't have enough of these and I have too much of this, whatever you have too much of, your body is going to want to urinate it out. Okay, that is, we'll get rid of it by the kidneys. And then we're going to try to generate hydrogen ions. So what we're going to do, we're going to bring this back down, bring this back up. Now, also, because it was low, one of the things you will see is if I can get my CO2 levels up, so one of the things I will do is see a low respiratory rate. I will see that my respiratory compensation, my lungs will slow down and let CO2 accumulate to push more hydrogen ions into the solution. Okay? And that is metabolic alkalosis. The way that I draw it, I hope, can really make it make sense. You have to draw it out repeatedly so you fully comprehend what's happening. These are things that in the when you're dealing with patients, these will definitely be things you have to fully understand. You can't just partially grasp it. It has to be fully understood. Okay. And here's some diagrams that show the metabolic stuff. Now, again, I always say Rome, respiratory is opposite, where CO2 and pH go in opposite directions. And I also like to say that acidosis is sliding down pH, alkalosis is kicking up the pH. The bicarbonate ions go in the same direction as pH, so metabolic is equal. Rome, respiratory opposite, metabolic equal. Okay. And here's a little chart that I put together just showing those things, very important relationships to know. This is kind of like if you think somebody has an acid-base disorder and you looked at it. Acidosis, alkalosis, acidemia, alkalemia. We're going to check their CO2 levels. How might we check CO2 levels? Blood gas. Arterial blood gas. We can look at that. Remember, CO2 is generally around about in arterial blood about 400 millimeters. About 40 millimeters of mercury of partial pressure. Where if it's up like above 50, definitely would be an issue. And also, if you look at it, remember it's right around, like I said, 45, 40. is your normal CO2 levels. We talked to being about 45 throughout the venous blood and about 40 in arterial blood. And you can look at that. And then you do bicarb. Now, one of the things they do is something called anion gap. You do not have to calculate anion gap. What you really do is we look at the two most important ECF, the primary kind of measured cations. These are really big ones: sodium, potassium, chloride, and bicarb. Okay. So what you do is you would go find, remember that bracket, if you guys have seen this before, that represents concentration. If you have done a panel on the patient, you would know their concentration in mill equivalent in sodium, which should be 135 to 145. Potassium, we know, should be 2.5 to 5. And then you add those two together. And then you add up chloride, 100 to 108, and bicarbonate, 20 to 28, and you add those two together. Then you subtract the two numbers, and that should give me a normal at 20 milliequivalents per liter. Now, this is used as a diagnostic tool. Now, I do teach it. I am not going to make you calculate it. Do not worry about calculating it in this course yet. But one of those things people always say, Leopard always goes into way more in detail than anybody else. It's not fair. Why do we do this? Well, one thing is, though, and I know I've always said this, but for you guys who want to be nurses in my class, I'm going to say this. A very good friend of mine, his wife is the lady who you will deal with when you go to clinicals. Because there is only one health system here, and that's she works with that one health system, and she does that, and she will tell me. She will know who you had for A and B. She has all that information, and she knows. But she has also told me that my students know what they're talking about, and she is glad of that. But I talk to people in the field, and I want to make sure that we do what we need to be doing. And something she said, it's good. She says, talk about it. Just tell them this is kind of what it's for. And you can see right here, they might use it if they want to check between compensated versus uncompensated, chronic versus acute. Things like that, for example. Acidosis, and very commonly used. Okay, why is it that potassium is so affected by this, guys, and sodium is so affected by this? Well, it should not surprise you because hydrogen ions are linked to aldosterone. Okay. So when you're dealing with DKA, diabetic ketoacidosis patient, watch their potassium levels. Okay. Here I have some things to kind of go through. Let's think about it. We have a 75-year-old male patient, Herbert. He's in his care. He has a history of COPD. He's not been using his oxygen tank. His arterial blood gas has a partial pressure of CO2 at 65 in his arterial blood. It should be 40. So obviously CO2 is up. So obviously we're thinking first, respiratory. It's elevated CO2. So we're thinking respiratory what? If you said acidosis, you're right. I want you guys to think. So pause if you had that. So why? Because he has elevated CO2. Now, one thing I didn't put here is I did not put his bicarb level being normal, and I kind of wish I did because it's a really good thing to have. And so his body, his lungs can't really deal with it, so he's going to be doing renal compensation, excreting hydrogen ions. 20-year-old anatomy and physiology student, Carrie, has an exam tomorrow, and she's failing to understand the material, so she begins to have a panic attack. She's hyperventilating. Her heart is racing. She feels so bad, her mother takes her to the ER, fearing that her daughter is having a heart attack. Blood test comes back showing her blood's pH is 7.5. We should know the average blood pH is 7.4. It ranges from 7.35 to 7.45. We know that partial pressure of CO2 is in the arterial blood is 40. This is 26, so extremely low. And we know that her bicarb 20 to 28 is normal. Now, I am seeing a normal level of bicarb, but I am seeing a very decreased level of CO2. So we know this must be a respiratory issue. Her pH is high. So she has what we would say, guys, is what? If you said she has respiratory alkalosis, then you're right. That's because she has the depleted CO2 level and the high levels of pH. So she's probably, if she's not able to get it up, she's going to be dealing with renal compensation. And, this might be as like, this is probably too close to home for you guys. Now, I've got a little baby boy here, Jackson. He's 4-week-old baby. He's been admitted to the hospital. He's been projectile vomiting for several days. If your baby's projectile vomiting for several days, I'm probably going to do this 2 days or 1 day. I might just say for a day. Because I think that if the baby's been going several days of vomiting, then one of my students actually said demonic possession. And I'm like, yeah, definitely would be demonic possession if for several days your baby. Well, so what I want to mention is, guys, your pH is 7.5, so that's high. Partial pressure of CO2 is 43, bicarbonate is 37. Now, wait a minute, bicarbonate 20 to 28. Bicarbonate has changed. Now, here, this is really not abnormal. Okay, CO2 is pretty normal. I put 43. Remember, around 40. 40 is a normal blood arterial level, but we definitely see it as high as 45. So I would say between 40 to 45, and that's kind of the way I was thinking about here. So, okay, good. That's actually normal. So if you're thinking it's high, so we're thinking alkalosis, but remember his bicarb is not right, so this is metabolic. And you're thinking, well, vomiting, so metabolic alkalosis, why? He's vomiting. And probably both kinds of compensation mechanisms. He's probably not breathing very quickly, little Jackson, and probably his kidneys are generating a lot of hydrogen ions, and he's probably urinating a lot of bicarbonate. So he probably has some more basic urine. So those kinds of things will be looked at. Remember, this is your 5 extra points that we're only allowed to give 5, and that is it. And print this. Basically, all you got to do is either you can get the whole page if you want to print the slide off, or if you just want to photocopy it, fill it in. I recommend you write these over and over and over and over and over again. I told you the 2 ways that I normally do things like that when I was a student. How did I do it? How did I study? I will say this, guys. I really have no special skills that you don't have. In some cases, you guys have things. When I was in school, you guys have an advantage of me. And why was that is I grew up in a poor family. We lived in a place called Possentrot Ridge, and if you can do it, if I can do it, so can you. But I want to let you guys know that don't think just because, oh, Will Lefford's got some kind of special thing. Remember, put Post-it notes, write them down. But I'd say write them down as many times as you can till they're in there. There will be at least 3 questions on the exam on electrolyte ranges. One of them, I will give you an electrolyte value. Actually, multiple electrolytes. I will give you my electrolytes from one of my blood tests that I had done. I have to have regular potassium, regular metabolic electrolyte panels done. My electrolyte panels are done at least probably every 3 months just to maintain and keep an eye on my potassium level. It's been able to be kept high enough. Sometimes just 3.6. Or 3.5 to 5. I have had it a handful of times, like 4.1, like firmly square in the middle, but it does drop sometimes, and we don't know why. But those are things, guys, that make sure you do understand. And I'm so sorry that says 3 minus. I got to fix that. It says 3 minus, not 2 minus. So I apologize for that. So without further ado, we are done on that one. Guys, thank you so much. If you please need anything, let me know. I'm always here to help. Please feel free to reach out. If there's lectures you would like to see me do on the YouTube channel, leave them in the comments below as well, because I post all of my lectures to YouTube, and that's kind of the point, is I want it available to everyone. My students can watch it. everywhere, more available than UJOT was. It's actually one of the reasons why I use it. It's more complicated, and it has been a little bit more of a problem. I actually had to end up redoing this because there was problems with the last recording, so I apologize. But guys, thank you so much, and I look forward to seeing you in the next one. Thank you.